Hi, welcome back. We left off on, we were briefly discussing Graves' disease, and we left off on calcitonin. So let's do a little talking about this. All right, calcitonin. This is going to be, it's going to be a hormone that's produced by the parafollicular cells in response to high calcium levels. So if it is in response to high calcium levels, you could then say, maybe calcitonin is going to be negative feedback, saying, hold up, slow down this calcium and concentration in blood, it's too high. Well, what is it going to be inhibiting? Parathyroid hormone is it is an antagonist to parathyroid hormone, right? Okay, so as a result, calcitonin is going to inhibit the osteoclast found in bone responsible for releasing chemicals and enzymes that digest bone matrix in order to release this calcium through the blood. If we have a lot of this high calcium levels, you want to put it somewhere. You want to store it somewhere. You got to get it out of the blood and put it somewhere. Where? In bone matrix. So you want to absorb it. You want to absorb that. So it's going to help stimulate calcium uptake and incorporation into the bone matrix, and it's going to prevent it from being released from bone matrix, right? Due to this inhibition of the osteoclast cells. So again, let's take a look at these parafollicular cells, which secrete the calcitonin. And remember, follicular cells secreting TH, right? Thyroid hormones. Okay, well, I introduced the parathyroid hormone, right, over here. So it would lead us to then discuss the parathyroid. So the parathyroid gland, let's just quickly take a look at this. Here is the thyroid gland. This is an image posterior, right, in this individual. And here are the parathyroid glands. Sometimes they can be more than 4. It sometimes depends. But yes, it's not surprising to find more than 4 parathyroid glands. Very important. Okay, let's go back and let's take a look at something. So the parathyroid cells, they secrete the parathyroid hormone. Now, let's look at the reverse of calcitonin. So parathyroid hormone is going to kick in when there is low blood calcium levels, or the concentration of calcium in blood is low. That's when it kicks in. Calcitonin responding to high, right? They're working in opposites of one another. Now, target organs, again, remember the skeleton. It is an organ. Organ, skeleton, kidneys, and intestines. Now, calcitonin, inhibiting that osteoclast, right? Releasing those chemicals and enzymes to that release the calcium. That was calcitonin. Well, in the case of the parathyroid, if the calcium levels are low, you're going to want to stimulate that osteoclast found in the vein and the bone matrix. So those enzymes can do some degradation, some cleaving, some breaking apart to release that blood glucose into blood, because parathyroid gland reacts to low levels, low in response to low levels. And as I told you before, I like that word, concentration, because we're really going to be looking at calcium per volume of sample. All right. So as a result, it's also going to enhance the reabsorption of calcium and secretion of phosphates. Phosphates found in bones, right? In that bone matrix, you're going to release some of those phosphates, and we're going to have those taking place. Promotes activation of vitamin D by kidneys, which leads to the reabsorption of calcium by the intestinal mucosa. All right, let's just briefly take a look into this. Low calcium, hypoglycemia. Okay, we got this guy, this one's low. What do we got to do? Are we going to increase the production of calcitonin? Heck no. We're going to increase PTH, parathyroid hormone, released from these little guys right here, right? So boom, and this hormone goes up. What's going to happen? Is the osteoclast activity going to decrease? No, that's what happens to calcitonin. Calcitonin, it comes in inhibiting the osteoclast, but parathyroid comes in and stimulates the activity of the osteoclast located in the bone matrix to release calcium and phosphatase. We also, since we have this situation occurring, we're going to have calcium reabsorption in the kidney tubule, activation of vitamin B by kidney, and absorption of calcium in small intestines. So that is how this works. This is a little brief breakdown for you. Okay, we are talking about the parathyroid. Well, let's go into hyperparathyroidism. If it's hyper, we can always take that chance, most likely, best educated guess. And if it's going to be hyper, creating a lot of, most likely it is the result of a tumor, which could be cancerous, right? Making lots of. So calcium's leaching from bones, this elevated calcium. Remember what it can do. It has a lot to do with our nervous system. So in this case, elevated calcium levels depresses the nervous system. And if you have a bunch of calcium running all lower through your bloodstream, well, you could possibly form kidney stones, right? Hypo, low, low, low. Not tumor, not gland tumor, not cancer. Low. So some sort of trauma, okay, that occurred, or possibly even maybe there was some sort of surgery done on the thyroid and you had some of the parathyroid glands removed, and as a result, you can have hypocalcemia, resulting in tetany, respiratory paralysis, and death. I put a little note here because we don't really go into great detail in tetany, but condition that is due usually to the hypoglycemia. Hypo, low blood calcium, and is characterized by spasms of the hands and feet, cramps, spasm movement of voice box, larynx. And again, here, an overactive neurological reflex. So we remember the adrenal gland, right? So we left the thyroid. We remember we are in the endocrine system. There are multiple organs responsible for hormone production other than the thyroid, right? So we're leaving the thyroid and we're going into the adrenal gland. All right, so the adrenal glands right on top of kidneys. Let's take a quick look and see what that is. All right, this is the adrenal gland. Okay, medullary cortex, right? These are these layers, and these different layers produce different hormones. So it's really in the actual adrenal gland, it's actually two glands in one in reality. It's the adrenal cortex, as I showed you, and the adrenal medulla. And these are going to be producing various hormones. Now, overall or collectively, the adrenal gland produces about over 24 different hormones, but these hormones are classified as corticosteroids. They're corticosteroids. And within the layers, we have the mineralocorticosteroids, glucocorticosteroids, steroids, and the gonatocorticoid steroid. I won't go into a lot of detail into these three, but I will discuss some of their main functions. For example, in the mineral, it's going to be involved in the regulation of electrolyte concentrations. When you think electrolytes, two things need to come in mind, two ions. That's sodium, potassium, right? Very important for blood volume, blood pressure, right? So that is what this hormone is going to be doing. It's going to be regulating those primary electrolytes. Well, what happens if we find ourselves in a hypersecretion due to adrenal tumors? Again, hyper, lots of, most likely tumor and cancer. So the aldosteronism is a hypersecretion and it results in, well, hypertension. So you're getting excess salts. You can have excess salts. The excess salt increases hypertension, and also you have swelling known as the edema. An excretion of potassium leading to the abnormal responsiveness of neurons and muscles. Now the glucocorticoids influence metabolism of most cells. Very important to keep that blood glucose levels constant, and these help maintain blood pressure by vasoconstriction. I discussed with that in terms of the internal diameter. If the internal diameter is contracted, you're going to increase that blood pressure, right? If you have a dilation, widening of the internal diameter, you're going to release some of that pressure. That blood pressure is going to drop, right? So one of the ones of the glucocorticoids is cortisol. This one, I put this little sign here because, man, it is important. Cortisol. Now, let's talk about some of the actions of cortisol. So cortisol causes the increase in blood levels of glucose, fatty acids, and amino acids. So the primary metabolic effect is gluconeogenesis. So in this case, it is glucose genesis, making of glucose from fats and proteins. And through this process, it's encouraged to do this so the glucose can be saved for brain fuel, right? We've talked about how important it is for the brain to have glucose. Now, let's look at a clinical here. The hypersecretion. Again, hyper, lots of, most likely, tumor, cancer of something, right? Somewhere. So we're talking about cortisol. So, hey, pituitary, even lungs, pancreas, right? Kidney, adrenal cortex. Or it could also be not a tumor or a cancer, but it could occur in the improper dosage and exposure of, got it, corticosteroids, the overuse of that. So we have something called Cushing's syndrome or disease. And sometimes the symptoms, what they are, is like a moon face, this buffalo hump toward the back, definitely weight gain, and also the production of more hair. Okay, sometimes this can be alleviated by removal of the tumor, or maybe some sort of cancer medications, right, or treatment, or discontinuation of drugs if it was due to the overuse of the corticosteroids, right? So Let's go take a look at this Cushing's disease. Here's an individual. So we have our patient. It was before the onset of Cushing's, and here is after Cushing's, right? You can see this. You can see the weight gain that has occurred in the individual's face, and also here you see this additional uh, area that is known as the buffalo hump. It's the fat on the upper back. So this is the Cushing's disease. Okay, let's look at the opposite end of the spectrum in terms of cortisol. We just discussed the high end. Let's go to that low end. So hypo, low, okay, Addison's disease. So in this case, again, with hypo, low, we're not going to be looking or thinking that it is going to be due to some tumor or cancer, because again, tumor and cancer, we're going to have high replications of cells, right? We're going to have more cells than normal, and these cells are going to be releasing hormones, but that is not the case in the hyposecretion, right? So in this case, deficient usually involves deficiency in the glucocorticoids and the mineral corticoids. So decrease in plasma glucose and sodium levels. And what are going to be some of the symptoms if it is the opposite of hyper secretion in terms of Cushing's disease, where the person is gaining weight, has a little bit more hair on the body? Well, let's go to the opposite with Addison's, right? And the way you think of it is A in the alphabet, low, Addison's is low cortisol. You think of Cushing's, A, B, C, higher, more cortisol. Also, in the same spectrum of A, B, C, think of A, low. You're going to have loss of weight. In the case of Cushing's, it's for weight gain. Also, let's go back to Addison's. Addison's, less hair. Baldness, okay? Baldness can be occurring. So in the case of the hypo and Addison's with low, guess what you can do? Give them the corticosteroid replacement therapy and bring that back up, right? Now, here's another interesting thing with the symptoms of this, or certain characteristics. The early sign characteristic is bronze, this bronzing of skin due to high levels of the adrenocorticotropic hormone, which triggers melanocytes, which are the cells responsible for producing melanin. So you're going to change that color of the skin pigmentation. So that's one of the early onsets of Addison's disease. Let's go here. We're still in the adrenal cortex. Let's look at the gonadocorticoids. Here, gonad, think gonad. Adrenal, sex hormones, right? So in weak androgens, male sex hormones convert to testosterone in tissues and some androgens, right? So may contribute to the onset of puberty, right? These are sex hormones. Appearance of secondary sex characteristics. Been seen also in increasing sex drive in women, and is a source of estrogen in postmenopausal women. So in hypersecretion, right, you're going to be producing a lot. Masculinization can occur. So not noticeable in fully developed males, but in those that are not fully developed males, you can see this characteristic occur. Now, females and boys, reproductive organs mature, secondary sex characteristics can emerge earlier. In hyper, in females, can produce facial hair and other other things can occur. Let's see. Okay. Let's talk a little bit about epinephrine. Hyposecretion, low, right? So hyposecretion, um, not too much situations occurring here in terms of hypo, but when you get into hypersecretion of epinephrine and yeah, get into high concentrations of epinephrine and the norepinephrine, you can have issues with your nervous system, which can lead to it's an imbalance. So uncontrolled sympathetic nervous system. So hyperglycemia, increased metabolic rate, hearts pumping faster. So you can also experience sweating and some nervousness. Now, pineal gland. Okay, let's talk about this a little bit. Remember endocrine, we're in the endocrine system. So pinealocytes secrete melatonin, not to be confused with melanin. Melanin, skin. Melanin, skin. Melatonin, think of those gummies that people take, right? Now, let's go through this and then we'll discuss a few things. Derived from serotonin, okay? Now, what is the effects of melatonin? Now, it could also have timing of sexual maturity and puberty, but most of us think of melatonin as the cycles for day and night. It can really throw people off when they're doing night shifts as well. It can have an issue with physiological process that slow rhythmic variations, body temperature, sleep appetite. So day and night, usually light is going to inhibit melatonin. As light decreases, melatonin begins to slowly increase. So with the use of cell phones and technology, we can't simply turn on and off the pineal gland's production of melatonin. It just doesn't happen like that. A lot of Americans struggle with sleep for this reason or reasons, in which someone is on their technical device and they're looking up stuff, right? They're looking up a lot of educational things to become more aware of the world that we live in. So they're looking up this information to really study, and they're inhibiting the melatonin. And they turn their device off and they think, oh, time to go to sleep. It doesn't work that way. Well, then finally, when they do go to sleep, the production of melatonin is kicking in, and then time to get up, and they get up and they feel so tired. Oh, why tired? It's because, well, you still have melatonin being produced. Your alarm went off. Your body was not naturally going to get up at that point in time. So also be careful with the intake of melatonin. Be responsible, specifically if you're going to administer this to children, right? It is not suggested to give this to children because they are bouncing up and down, jumping up and down, and they're perfectly healthy and they're not sick. That is not a reason to give melatonin, okay? Do not do that, right? That is not something that should be done. I just want to make sure that's clear. Here, let's take a look at some of the endocrine organs: penile, hypothalamus, pituitary, thyroid, and then posterior to the thyroid, we have the parathyroid glands, usually 4 parathyroid glands, and we have the thymus, the adrenal glands above the kidneys, we have the pancreas, and gonads, ovaries, and testes. We won't go Well, yes, well, actually, we will go into the pancreas, but there are some other ones that we won't go quite into. In terms of pancreas, and we definitely have to cover the pancreas, is because of these alpha cells and beta cells. Wow, look at this. Alpha cells going to produce glucagon, glucagon, hy- hyperglycemic hormone. Beta cells producing insulin. Wow, that is some important stuff right there. Hypoglycemic hormone. Both are hormones. We're in the pancreas. This is very important. The pancreas. We will then dive into diabetes, and we will look at that more in depth and how these alpha cells and beta cells and various receptors, whether they are no longer responsive, and how that plays a role into high glucose concentrations in blood. Glucagon. So when does this happen? This glucagon by the alpha cell. Okay. Well, triggered by a decrease in blood glucose. That's what's going to happen. Okay. So it's triggered by a low decrease low blood glucose levels in blood. Okay. So it's going to rise glucose levels by targeting the liver. So glucagon is going to go to the liver and say, "Hey, what's going on here, man? Hey, I got to get to this glycogen." Remember what glycogen is, right? This large polymer, many repeating units of glucose. So you have this large structure of polymer, and if you're low on glucose, you want to break it up. You want to do catabolism. You want to break it up and throw that glucose back into the blood so you can reach homeostasis. Well, that is gluconeogenesis. Gluconeogenesis. So synthesize glucose from lactic acid and other non-carbohydrates, gluconeogenesis, and ultimately released through the blood. So let's repeat. We have these alpha cells, right? Produce glucagon when glucose levels are low. Glucose levels are low. So we break up this glycogen so we can release glucose into the blood. And where is this taking place? Liver. Okay. Insulin. The opposite. It's gonna do the opposite. And that's one of the great things about this that we're covering. If you're struggling with brain space, right, and crunching time, which we try not to do, hey, pick one. Make a choice. Do you want to pick glucagon? Because if you know what glucagon is, then insulin's going to be the opposite, right? Insulin's going to be opposite. So if you know what insulin does, or if you know what glucagon does, then you know what the other does. It's just the opposite. So secreted when blood glucose levels increase. Right? Opposite of glucagon over there. So, all right, blood glucose levels too high. So we need insulin is gonna have to lower this. So that's the negative feedback. Glucose high, gotta send that negative feedback. Say, hey, insulin, do something about this. What you gonna do? Well, it's going to enhance the membranes on cells to then transport glucose into the cells. Okay, so they can be utilized. So glucose into fat cells, muscle cells. Also, it's going to inhibit the breakdown of glycogen to glucose because we're topped off. We do not want more glucose, buddy. So let's inhibit that glycogen from breaking down. We don't want glycogen to do that, right? Also, we're going to inhibit the conversion of amino acids or fats to glucose because glucose can be made by amino acids and fats. So insulin, not needed for glucose uptake in liver, kidney, and brain. Also plays a very important role in neurodevelopment, learning, and memory. And look at this. Here's the old tyrosine comes in, binding the tyrosine kinase, anything in ACE, enzyme. Receptor triggers cells to increase glucose uptake. That is what we were talking about right here. So we're trying to get glucose to be transported inside because it's so much in the bloodstream. So you want cells to take them in because cells need glucose. All right. So binding to that tyrosine kinase enzyme receptor, triggering cells to increase glucose uptake into the cell, therefore decreasing glucose levels in blood. Okay. Insulin also triggers cells to catalyze. See that word, catalyze? Remember? Metabolism, anabolism, catabolism. So cata, breaking of glucose for ATP production. Okay? You can polymerize glucose to form glycogen. That makes sense. In the other case, you have glycogen, polymer of glucose, repeating units, was in the term of glucagon. They were breaking apart. Break down glucagon into glucose. Well, if you can break down this into glucose, then you can get a bunch of this to make glycogen. Okay, so let's go over here. Polymer, many of, right? Glucose. There's a lot of glucose in the blood. What can we do with it? What can we do with it? Hey, we can make glycogen. Right? Get it out of that blood, make some glycogen, and convert glucose to fat, particularly in adipose cells, fat cells. Factors that influence insulin release. Well, we already talked about in terms of glucose in blood. Elevated blood glucose levels. Again, it's a repeat, right? Rising blood levels of amino acids and fatty acids. That's part of it. So let's briefly take a look of what I said in terms of the picture. And we're trying to have some sort of homeostasis balance. All right, let's start like a clock. Okay. Stimulus. So we have increased blood glucose, high concentration of glucose in the blood. What's going to happen? Hey, pancreas, got to do something. What are you going to do? I'm going to make some insulin. I'm going to make some insulin and come over here to these receptors. Talk to these receptors like, hey, receptors, what am I going to do? Hey, take that glucose in, buddy, man. Get some metabolism going on over there. I have too much in the bloodstream. So it's going to be like, all right, hook up with the receptor on the membrane. Get this glucose uptake by the cells. All right, so once this can happen, uptake by cells, then you could have blood glucose falling to a normal range, and then you can plateau to you can reach a homeostasis or a good level at approximately 9 milligrams per 100 ml sample. Or you can do this, and insulin can go boom over here, and it can come to the liver, and it can say, hey, we have a lot of blood glucose. This glucose needs to start binding to itself, so it cannot be transported into the blood. And we need to get a bunch of glucose binding to itself. You need a bond, buddy. You need to make that polymer of glycogen, right? Once this starts happening, you get a bunch of glycogen. You're going to remove those sugars from the blood, and you're going to then reach, again, a normal blood glucose level. All right, other end of the spectrum. Let's look at a stimulus. Low blood glucose level, low. Again, looking to that pancreas to do something, buddy. Hey, what are you gonna do? It's low. Hey, the opposite of insulin is glucagon. All right, so we're at low blood levels, and it's gonna do the opposite of insulin. So instead of forming glycogen, large molecule polymer of glucose, it is going to catalyze. It is gonna break down glycogen and release glucose into the blood tipping it back up from a low to a good range again, right here. Hope this makes sense, ladies and gentlemen. So diabetes mellitus, DM. We have two types, right? Both in the case of hyposecretion of insulin, and then we have hypoactivity of insulin. So in the case of type 1, that's genetic. A person has passed on this genetic information, and pancreas non-functional, right? Type 2, that's you. That's how I remember it. Type 2, that's you. That means poor healthy, poor diet, poor lifestyle. You can throw in there a little bit of genetics that can contribute to that too. And sometimes it's zero genetics in type 2. It's all you, it's all your decisions, Being a couch potato, very little exercise, you know, just yeah, it gets bad. So what happens here, and since so much sugar in body, is the insulin receptors get tired over time. I put tired, okay, in quotes, too tired. I don't want to call it that. We have more scientific terms for it, but insulin resistance. So no matter what you do or how much insulin you take, hey, those receptors that were responsible for taking in that sugar into the cell, they've been used so much. Because remember what insulin is doing, it's responding to high blood glucose levels, large amounts. You want to do something, you want to get these taken in by the cells, and there's these receptors. But if you've been living a lifestyle just drinking sodas and just eating unhealthy, lots of different sugars into your body for years and years and years, decades and decades and decades, well, hey, things have a limit. You know, your car, you drive your car, you know, when you abuse your car, you know, your tires can get affected, your engine can be affected, you know, your suspension can be affected, the shocks, the upper and lower control arms. Same thing with a car or anything you use. So insulin receptor in terms of type 2U. So here are some 3 cardinal signs in terms of diabetes mellitus. Polyuria. You're going to have this huge urine output because glucose acts as an osmotic diuretic. Lots of urine output. Polydysplasia. Excess thirst. This loss of water and salts. So very thirsty, very thirsty. Polyphagia. Excess hunger and food consumption. Why? Well, the cells are not absorbing, not taking in that glucose, and as a result, they're starving. They need to do that glucose, right? Got to get that ATP. Where are you going to get it from? Got to get it from that glucose. But if your cell doesn't have that, how are you going to convert glucose to go through glycolysis? Krebs cycle, electron transport chain. It doesn't happen. So as a result, sends signals to the body. The body starts consuming, being very hungry, and just doesn't really work out. So when sugars cannot be used as fuel, as in DM, fats are used. So you have these high levels of fatty acids in the blood. Now, these fatty acid metabolism results in the formation of ketones. And believe it or not, it can even make, I don't think it mentions it here, but acetone. You can even smell acetone in a person's breath that has diabetes mellitus, that is undergoing ketoacidosis. So a lot of keto bodies in urine. So untreated ketoacidosis can be severe. It's a problem. It can lead to a coma, and also death. Hyperinsulinism. excess insulin, excessive insulin secretion. Oh boy, what a tongue twister. Sorry. Long day. Causes hypoglycemia. So you're getting these low blood glucose levels, nervousness, anxiety, disorientation, um, even death. So since insulin, remember, responsible for moving that blood glucose into cells and so forth, you're lacking. You're lacking that you're lacking that sugar. Because again, let's go back, right? Look, increase, it's gonna get this and it's gonna uptake it in cells. Insulin, glucose gonna get converted to glycogen, and then glucose is going to go into cells. So you're not gonna have much. When there's a bunch of insulin, you're not gonna have much of it in your running through your blood. So you're gonna have that trigger for sugar ingestion. Feel free to take a look at this chart. It's a nice little chart. I like it. Shows kind of shows what we're talking about. And we're going to stop it here. We're not going to go through hormone secretion of adipose tissue, gastrointestinal tract. We focus on the main ones. I know this chapter is very long. We'll get into chemistry. So we're going to stop it, and we're going to end it here with the DM, okay? All right, and by the DM, not direct messaging, guys, okay? Diabetes mellitus. All right, everybody take care.